Okay, so since I'm still trying to avoid making that stroke video and we're talking about neurodegenerative diseases, I figured we'd tackle on one of the biggest ones, which is Alzheimer's disease. So, Alzheimer's disease is one of the leading causes of dementia, and while we've been able to identify a couple of causative gene defects and risk factors, we still don't really understand the exact mechanism of the disease. What we do know is sort of the patient population that it affects. So Alzheimer's is really considered to be one of the diseases of the elderly. It affects women more than it affects men, and it usually has an age of onset of greater than 65 years. Now, the incidence of Alzheimer's disease actually steadily increases with age, which is to say basically 17% of people in the 65 to 74 age bracket will be diagnosed with Alzheimer's in the United States. And then that number jumps all the way up to 36% in the age population greater than 85. So yeah, 1 in 3 people will have Alzheimer's disease after the age of 85, and it's the 6th most common cause of death in the United States. So basically, it sucks. And I know some young folk in the audience out there are thinking yeah, okay, this blows, but it doesn't affect people under the age of 65, so meh. But yeah, that is usually true, but in cases of familial Alzheimer's disease, you'll actually see an earlier onset, and that's about 10% of all Alzheimer's disease diagnoses. Also, care about old people, asshole. Okay, so we do not have a cure for Alzheimer's disease. So identifying and preventing further degradation is really important in this disease process. It's key for these patients. So that's why you want to be really familiar with not just the clinical presentation, but also the risk factors. Which raises the question, what are the risk factors? So there are a couple of genes that have been identified, and our first gene that we're going to talk about is amyloid precursor protein gene, or APP, which is on chromosome 21. And unsurprisingly, it codes for the amyloid precursor protein. And APP is the genetic mutation is in 10 to 15% of all early onset cases of familial Alzheimer's disease. Important note about the APP gene. So APP is located on chromosome 21, which means patients with trisomy 21 or Down syndrome have a much higher or an increased risk for the development of Alzheimer's disease. And the age of onset for patients who have an APP gene mutation or this particular risk factor tends to be around the age of 50, so you need to be mindful. So the next genetic risk factor we're going to talk about is presenilin 1 and presenilin 2. Presenilin 1 is located on chromosome 14, so you might be thinking, okay, so presenilin 2 is probably also located on chromosome 14, or maybe chromosome 15. No, it's located on chromosome 1. These code for PSEN1 and PSEN2 respectively. So presenilin 1 is super important because it's linked to about 50% of all familial Alzheimer's disease. And that's, insane. And now mutations of PSEN1 do tend to have that earlier onset that we kind of talked about above. So patients with this mutation will experience onset of Alzheimer's disease at a median age of 43 years old. Presenilin 2 mutations are much rarer, and they tend to have a later onset of around 54 years old. And our last genetic risk factor that we're going to talk about is actually your ApoE, which is located on chromosome 19, and it codes for the apolipoprotein E. And this is an interesting one because your risk actually depends on which specific allele of this gene that you have. So which version of ApoE you have changes your risk. So if you have ApoE4, you're at an increased risk for late onset Alzheimer's disease. If you have ApoE2, you actually might receive a protective effect, so that reduces the risk of late onset sporadic Alzheimer's disease. And then if you have ApoE3, it seems to have kind of no effect. It neither increases or decreases your risk of developing Alzheimer's disease. I don't know anything about ApoE1. I'm not even sure it exists, I'm going to be honest. So yeah, those are our genetic risk factors. We have the APP, which is on chromosome 21. We have presenilin 1 and presenilin 2, which are on 14 and 1. And then we have ApoE, which is on chromosome 19. And that's the summary of our genetic risk factors. But we're not actually in the practice of just genetically testing every patient who walks through our door. At least not yet. So what are non-genetic risk factors for Alzheimer's disease? The first big one is age. I kind of talked about this before, but pretty much the older you are, the more likely you are to develop Alzheimer's disease. And then the other big risk factor is family history, and it's a family history of Alzheimer's disease or dementia. And this is a really strong predictor of early onset Alzheimer's disease. Okay, and then your other risk factors are kind of more generic and sort of what you expect. So that's going to be diabetes, obesity, dyslipidemia, hypertension, peripheral atherosclerosis, cerebral vascular diseases, coming from a low socioeconomic background or having a low educational status. African American or Hispanic populations have a higher risk compared to whites. Lack of physical activity, or is it just like an independent risk factor? It's not good for you. A history of traumatic brain injuries. And then there's environmental factors. So secondhand smoke and sleep deprivation. Both of these increase your risk for developing Alzheimer's disease. Which, yeah, that was a lot. I'm sorry, but living is a risk factor. Okay, so now we know these risk factors. What actually happens to these patients? What is this disease that I'm talking about? Let's talk about the clinical signs and symptoms and then its pathophysiology. So Alzheimer's disease symptoms can be broken down into cognitive and non-cognitive features. And depending on the patient, the level or severity of their Alzheimer's disease and their own personal social skill and their own ability to create sort of workarounds, it can be hard to identify some of these features. The most common symptom, and probably the one that you're thinking of, is a short-term memory impairment. And like I said above, that can have kind of an insidious onset, so it can be difficult to identify exactly when that began. And it has a slow progression. And what it does is it actually affects episodic memory first. So episodic memory is a category of long-term memory, actually, and it involves your ability to recall specific events or situations or experiences. So I always like to think of episodic memory loss as like losing an episode of a TV show. You remember the characters and what they do, and you remember how to act, but you can't recall the events that happened in the episode that you lost. And Alzheimer's disease is progressive, so what happens is you lose more episodes with time. Okay, so other than the short-term memory impairment, patients can have language impairment, which will go from impaired naming to impaired comprehension and then impaired fluency globally. And they'll also demonstrate temporal or spatial disorientation, which is to say that Alzheimer's disease patients are not usually oriented to person, place, time, and events. These patients will also experience executive dysfunction and impaired judgment. So, those are the cognitive symptoms of Alzheimer's disease: memory loss, language impairment, temporal and spatial disorientation, and executive dysfunction. The less common symptoms are what I like to call the A's. So it's aphasia, apraxia, alexia, agnosia, and acalculia. Aphasia is that language difficulty, and what you see in Alzheimer's disease is a primary progressive aphasia, usually characterized specifically by word-finding difficulties. Apraxia is difficulty with the coordination of movement. You might remember it from the Parkinson's video. Alexia is an acquired inability to read due to a central processing dysfunction, also known as what happens to pretty much all of us when we pick up a complicated textbook or we're trying to read the first question on an exam and we're panicking. Agnosia is the inability to process sensory information that results in a failure to recognize and identify objects, persons, and or sounds. And finally, acalculia is the inability to perform mathematical tasks like difficulty with counting, adding, and subtracting. So all of these are kind of specific cognitive impairments that may characterize a patient's experience with Alzheimer's disease. And, the amount in which they're there and present and how specifically they affect a patient is going to be variable. So the cognitive impacts of Alzheimer's disease is kind of functionally the same, but it'll look different from patient to patient just based on their own strategies and the way that they've organized their life. There are also some non-cognitive symptoms. These patients may demonstrate behavioral changes. It's usually apathy or aggression, and they can develop mood disorders like depression. You may also see anxiety and selective mutism. They can develop urinary incontinence as well as sleep disturbances like insomnia. And then patients can also have hallucinations and paranoia. And then finally, these patients can actually have seizures and myoclonus. Myoclonus is just a brief shock-like involuntary twitch of a muscle or a group of muscles. So basically, there's these cognitive and non-cognitive impairments. And in general, Alzheimer's disease is an extremely scary disease for both the patient and the family. The patient will often retain enough cognitive ability to tell that something is going wrong, especially in the beginning, but they can't contextualize what's happening to them. Which actually saliently brings me to my next point. What is happening to them? The pathophysiology of Alzheimer's disease is actually quite complicated, but we're going to talk through it. So in my brain, what I do is I kind of characterize it into three mechanisms that all contribute to this disease. And that's senile/neuritic plaques, neurofibrillary tangles, and reduced cholinergic function. So, senile plaques, or amyloid plaques, these are extracellular manifestations located in the gray matter of the brain. And these plaques are made largely of A beta protein. And this is believed to occur because of an enzymatic cleavage of the transmembrane APP, remember APP, we talked about this, by beta and gamma secretase. And just to recap, because I don't remember anything that's happened more than a minute ago, APP is amyloid precursor protein. So when you cleave it, it becomes amyloid. Right, so like I was saying, APP gets cleaved by beta and gamma secretase. This creates A beta peptide, aka amyloid beta. And these A beta peptides aggregate together with tau proteins and microglia to form these insoluble plaques. And if having a bunch of insoluble plaques in your brain wasn't bad enough, they actually seem to have some kind of neurotoxic effect. Now, the mechanism of how they have this neurotoxic effect is, we don't know because we don't know anything in medicine. But a lot of the research in therapeutics is kind of focused on understanding and stopping this mechanism. So our other mechanism that we're going to talk about is neurofibrillary tangles. And these are intracellular, so they happen inside the cell. And these tangles are formed of hyperphosphorylated tau proteins. So tau proteins are an insoluble microtubule associated protein, and the existence of this tau protein-based neurofibrillary tangle in Alzheimer's disease is why Alzheimer's disease is actually considered to be a tauopathy, which is not very important to this video, but is cool. So what's happening? So what happens is you have this increased phosphorylation of tau proteins, and this causes the formation of intracellular fibrils, which have a neurotoxic effect. And basically, the more of these tangles you have, the more pronounced your cognitive impairment is. Someone out there is screaming, correlation is not causation, which good, they should be. Because yes, we are not actually sure if this causes neuronal loss or if it is an effect of the neuronal loss. Okay, so our final mechanism is this reduced cholinergic function. So acetylcholine deficiency is associated with loss of cholinergic nerves like the one in our brains, and therefore is associated with a decline in cognitive ability. Other neurotransmitters are not affected as badly in Alzheimer's disease, and we're still pretty confused about how all of this shakes out. So do with that what you will. But basically, you see degeneration of the cholinergic neurons in the brain in the nucleus bacillus of Maynard. And if you remember that in 2 months, you terrify me. But the knowledge is out there. So there you go. Nucleus bacillus of Maynard. And a lot of our therapeutics are actually focused on this fact. Not on the nucleus bacillus of Maynard, but on the impact of this acetylcholine deficiency. Okay, and the final thing that we see in Alzheimer's patients is this thing called Hirano bodies. Hirano bodies? Hirano bodies. Okay, so you can see these amyloid plaques, your tau proteins, and then you have these weird, intercellular rod-shaped eosinophilic aggregations of actin and actin-associated proteins in the neurons, and this is usually in the hippocampus. This isn't that helpful because you can see this in other neurodegenerative diseases like Creutzfeldt-Jakob or mad cow, and you can also just find this in normal elderly patients. So don't worry about it. And that was our extremely zoomed in, medical dense look at Alzheimer's. But let's step back a little. What is actually happening? These patients are basically going through cerebral atrophy, deaths of part of their brain. And in patients with Alzheimer's disease, the most obvious and the earliest signs of this are in the hippocampus and the parahippocampal cortex, which makes sense because these are the regions primarily associated with episodic memory, and that is our big symptom of Alzheimer's disease. And it'll start small and it'll get big. So first you'll see axonal degeneration or neuronal loss, and then you'll see diffuse cortical atrophy as the disease progresses. So that's the stuff that we will see in the patient's brain, but we don't normally slice open patients' brains when we're trying to figure out if they have Alzheimer's disease, because that would kill them. So how do we diagnose it? So first things first, you want a strong clinical suspicion, which makes sense because if you don't have a clinical suspicion that this is the disease, you've lost the race out the gate, right? You need to know that you're looking for it. So basically, what are the diagnostic criteria? So the first thing is insidious onset. So, normally Alzheimer's disease patients, their symptoms are first noticed by their relatives. The other thing is objective confirmation of progressive loss of function in at least 2 cognitive domains. We'll talk about that a little bit more, but usually we're talking about memory impairment. Then you need impaired activities of daily living. So that's going to be things like difficulty in the workplace. And then you need no other plausible explanation, right? Alzheimer's disease can't be caused by something like delirium. So I just said a bunch of like nonsense words. How do we actually establish these things? Like, it's one thing to say objectively confirmed progressive loss of function in at least 2 cognitive domains. How do we establish that? So we assess cognition with neurophysical tests like the mini mental state exam or the Montreal cognitive assessment. And I'm not going to go over these because all of these exams are like fucking 50 questions long and I'm lazy. And these can be used to establish memory loss and cognitive or functional decline. There are many other tests other than the mini mental and the Montreal cognitive assessment, but those are really kind of our 2 big name ones. So some hospitals will also have you do functional testing. It really just depends on the protocol and, where you are and how much time you have and what you're feeling that day. Okay, great. So these tests can be used to establish that a patient has dementia. But now that we know that the patient has dementia, what are we going to do next? So first things first, what we want to do is we want to rule out other causes of dementia, specifically our reversible causes. So to do this, we want to review the patient's medications as they could be a cause. You also want to do laboratory tests to rule out hypoglycemia, hypothyroidism, and vitamin B12 deficiency. The other thing you kind of want to do is you want to have a very strong clinical assessment because you want to rule out pseudodementia, which is an aspect or an element of major depressive disorder. Okay, so let's say that we have managed to rule out all of our reversible causes. Now we're going to move on to imaging because, of course, you are. So the first thing you're going to do is an ECG because why wouldn't you? We should always check. Like, if their heart's not working, we're going to have problems. It should be normal, or you might find a slower basic rhythm in patients with dementia. And then we dive into our neuroimaging, which makes sense because we're pretty sure this is a problem with the brain. We just wanted to rule out that nothing was happening with the heart. So our first thing is our CT MRI, and in dementia patients, you should see signs of generalized or focal cerebral atrophy, right? And that can look like enlarged ventricles or narrowing of the gyri or prominent cerebral sulci, which is to say like the grooves in the brain that you see, the squiggly shit, they might look bigger or deeper. Patients may also have this thing called hydrocephalus ex vacuo, which is when the ventricles and the subarachnoid space appear enlarged due to the loss of brain tissue. And this is important because the intracranial pressure and the flow of cerebral spinal fluid stays normal, which if it's not, that's a different problem and we need to like assess and address that. And remember, we said that Alzheimer's disease disproportionately affects the hippocampus, so we expect to see more atrophy at those sites. Okay, the next thing we might do is a PET scan, and we might do a positron emission tomography scan or an FDG PET. And this looks at the uptake of a specific radio tracer, and it gives you an idea of the relative metabolism of different parts of the brain. In Alzheimer's disease, you might see temporoparietal hypometabolism, which is to say that you might see like slowed or decreased uptake of this radio tracer because those areas are not using as much energy. Okay, and the other thing you can do is a cerebral spinal fluid analysis, or CSF. And what you expect to see there is actually an increase in phosphorylated tau protein and a decrease in beta amyloid proteins. And this decreases because the beta amyloid proteins are aggregating in the cerebral fluid instead of passing into the CSF. Okay, so now we know, how to look for it, what the risk factors are, what the clinical signs are, and how to diagnose an Alzheimer's patient. So let's talk about what we can do for these patients. Unfortunately, the short answer to that is not much. There is currently no curative therapy for Alzheimer's disease. But we can do things to slow the progression and sort of, prolong the times in which they're able to manage the activities of daily life. So for mild to moderate patients, you can give an acetylcholinesterase inhibitor, and this increases the amount of circulating acetylcholinesterase, which seems to help. And then for moderate severe, you might give an NMDA receptor antagonist, specifically memantine. And what it does is it blocks excessive glutaminergic transmission, which seems to have some kind of neuroprotective effect. And then from there, we want to focus on supportive care and the treatment of associated symptoms. So, we talked a little bit about how aggression and psychosis can occur in these patients. So we want to treat those with low dose antipsychotics. And we usually use our atypical antipsychotics like risperidone. And then, these patients can suffer from depression. So SSRIs like citalopram can be used. Now we need to be careful because we want to avoid using drugs with a strong anticholinergic effect in these patients like diphenhydramine because these patients are suffering from a deficiency there and we do not want to make it worse. And finally, as always, drugs are not the only way to treat a patient. So the first thing you're trying to do as soon as these patients are diagnosed with Alzheimer's disease are some lifestyle modifications. I know it is exceptionally preachy for a medical student to say you need to stick to a regular sleep schedule, but that shit do be helping. Adhere to a regular sleep schedule. Try to maintain a familiar environment and remove ambient noise for these patients. Other tactics can be used to diminish the impacts of executive dysfunction on the activities of daily living, just the same way, you would coach students and children who have developed executive dysfunction. Cognitive rehabilitation has actually yielded some promising results in the last few years, and that's things like memory training through puzzles and games. And its aim is to support memory retention and develop strategies to compensate for cognitive and functional decline. And finally, physical activity has actually been shown to both improve the physical strength in these patients and also slow cognitive decline. The other thing you want to remember is that Alzheimer's disease is not without its complications. Aspiration pneumonia is the most common contributing factor to Alzheimer's disease-related mortality. These patients are also at increased risk of malnourishment and dehydration, both because of their age and also because they often just forget to eat or drink. And finally, Alzheimer's disease is a risk factor for intracranial hemorrhages, and that's because the cerebral amyloid angiopathy, or these, all these plaques, which increases the risk of a bleed. Yeah, so the prognosis for these patients is not great, with mean survival time being about 3 to 10 years after diagnosis. And ultimately, Alzheimer's disease is an extremely painful and extremely difficult disease, not just for the patient, but also for the patient's family. So setting up the patients with support and being mindful of the strain that this disease can have on the caretaker is an important part of the treatment. So we do not have a cure currently, but medicine is constantly evolving, and who knows what the future could hold for these patients. So until then,